Go. Hi everyone, welcome to another session of PhysioTV. I am Dr. Anagha Kadam, Assistant Professor in Department of Musculoskeletal Physiotherapy, SIOR COP. Today we are going to talk about differential diagnosis for knee pain. I'll just share my PPT. I hope I'm visible. So when we talk about knee pain, it is very difficult to segregate the different symptoms, signs, and conditions of knee pain. So today we are just going to highlight the major issues and how we can differentiate between the different conditions. Um, So these are the contents for today's presentation. Will be having a brief intro about the knee complex in general and how are we going to how are we going to do the differential diagnosis according to various sections, according to history, uh, by the anatomical side, and according to the structures that are involved. When we talk about knee, we are usually dividing the knee complex into two parts, that is tibiofemoral and the patellofemoral joint. Knee joint is the largest articulating surface of any joint, and it is a weight-bearing joint. So it is not surprising that it is among the most commonly injured body parts. It is very complex structure, and to diagnose any pain of the knee is quite difficult. So we need to have a proper understanding of the structures that are present in the knee and what are the forces or symptoms that can lead to knee pain. So to narrow it down, we can divide the sections into history with focusing on physical examination and when to use a special test and the imaging and the laboratory studies. So when we talk about knee pain, the diagnostic category plays an important role. See, means if the patient comes to you, you have to be very sure that what the diagnosis can be. So we can divide it into three parts. Like this can be the most likely cause of it, and this symptom or this condition should be ruled out, and this won't be happening. Like in ACL, if the patient is complaining of hyperextended knee while the patient was injured, you don't need to see for IT band tightness or uh, hamstring tendinopathy as such, but you need to rule out any other meniscal injury or ligamentous injury, and obviously most likely ACL injury. So that's how you need to segregate the diagnosis or the kind of trauma. When we talk about history, we need to the first and foremost step we need to take is to ask the patient or invite the patient specifically to tell his or her own story of how the injury or trauma happened and what did he or she felt while the trauma was happening. So that will give you a brief idea about the symptoms and the forces that were acting on it while the trauma was happening, right? So specific to knee joint, other general examination, I guess we all know what it is. But specific to knee joint, there are some things that you need to focus on, like the forces that were acting on it, or the symptoms, or the effusion, right? So, but before doing the history, there is a most important one is the one of the most important part that all the most of the physios miss is segregating the conditions or narrowing it down according to the age group, right? So the most common cause of knee pain for by age group, if you can see the slide, you can I have mentioned it in three groups, like children and adolescents, adults and older adults. When a children or child comes to you, you need to be sure to check for all these conditions: patellar subluxation, osteoarthritis lesion, patellar tendinitis, osteochondritis disease, preferred pain. And when an adult come to you, you cannot obviously check for OA or something, right? because it is a degenerative condition. Yes, there are some special cases, but mostly, if you see, there will be patellofemoral pain syndrome, chondromalacia patella, medial plica syndrome, where sensor is bursitis. There will be history of any trauma, ligamentous sprain as such. Then meniscal injury is very common. We have to also rule out rheumatoid arthritis, Ritter syndrome, and septic arthritis. If an older adult comes to you, you have to understand the some conditions are more prevalent in older adults compared to the younger generation. So you have to check for osteoarthritis, cystic induced inflammatory conditions like gout, pseudo gout, or Baker's cyst, right? So you need to have a clear understanding of how which conditions are more prevalent in which age group, so that you can narrow the diagnosis to your final diagnosis. So as you can see on the slide, I'll just quickly give a brush up. This is a quadriceps muscle, and this is the tendon. As you can, this is the patella and the shin bone, and this is the patella tendon, right? So the pain occurring to the this site denotes the uh, inflammation or involvement of that structure. Similarly, here you can see pes ansaris, bursitis can happen over here. Then cementinosus tendon is over here. So the inflammation in these region, anatomical region, give you a landmark to point out that this condition can be more uh, prevalent in your patient. In history, as I said, the most important step in history is to invite the patient to tell his or own story. But after that, you can check for some symptoms, or you can ask the patient for some. You can ask the patient some questions regarding the history that will give you a proper idea that what the diagnosis can be. So in history, you can ask the patient if there are some locking episodes or popping, if the patient heard any popping sound while the trauma was occurring, or if the patient is feeling any uh, giving away type of feeling of the knee. So that will help you in diagnosing it properly. So the patient complains of the history of locking episodes. So it goes towards meniscal tear. Then if the patient complains, if the patient has heard some popping sound while the trauma was occurring, at that time there was ligamentous injury properly. There will be chances of ligamentous injury or complete rupture of the ligament. So that can be seen. And if the patient complains that there is episodes of giving away, so there are chances there is ligament instability or patella subluxation or some ligament rupture. So that can be seen. So timing and amount of joint effusion, which is quite seen in knee joint, plays an important role in diagnosing the condition. So if the patient has effusion and which has a rapid onset within the 2 hours of the injury, then it goes towards ACL rupture, then fracture of proximal tibia, that is tibial plateau. Then if the effusion is on the slower onset, 24 hours to 34 hours, with mild to moderate effusion, then it goes towards meniscal injury or ligamentous sprain. And if there is a recurrent effusion after do activity, sometimes the patient complains that after if I do some exercise or if I do some activity, some kind of activity, the effusion reoccurs. So what will it denote? It goes towards meniscal injury. So we need to be very particular about our listening skills while the patient is giving you history, or we need to be very particular about asking some questions to the patient so that we have a clear idea to narrow down the diagnosis. So mechanism of injury, which we usually don't notice or we don't dig in while asking the patient for history, plays an important role. So when the patient complains of any trauma, we need to imagine or think that where the force is being applied or where the force has been uh, applied or put on the joint, right? So if there is anterior force applied on the proximal tibia while the knee is in flexion, right? It denotes towards injury to the PCL. Whereas there is a direct lateral force to the knee, wherein we can see this type of force in football players, force negating a valgus load. So it denotes towards MCL, posteromedial capsule, then medial meniscal ACL injury. When there is medial blow that creates a varus force that comes towards a lateral collateral ligament injury or posterior capsule injury. And some of this load that occurs is also indirectly there, which we need to properly figure out, right? So if the patient complains that after moving or quick stop, if he takes quick stops and sharply turns and creates deceleration force or something, if you can see, then it points towards ACL injury. Then posterior translation plus flexion, as I said, goes towards PCL injury, hyperextension of knee while the patient trauma was occurring and there was hyperextension of knee. It goes towards ACL injury or meniscal injury. The patient says he was walking and then suddenly he twisted. So sudden twisting or pivoting motion creates shear forces, right? So it goes towards meniscal or PCL injuries. A combination of both, but two or more forces can easily occur simultaneously. That goes on to injury to the multiple structures. So you need to figure out properly that how you are going to go towards your final diagnosis, right? So in history, we can go with mechanical symptoms, then effusion, then the forces that applied and non-contact forces. I hope I'm being clear till now. So the second